Assalamu alaikum. Welcome to the 23rd Shaukat Khanum. Assalamu alaikum. Welcome to the 23rd Shaukat Khanum Cancer Symposium. We have two sessions on hematology and transplant. This is the first session. This is on the hematological malignancies. We have 3 talks, and each talk will be 20 minutes. So our first speaker is Dr. Azhar Shafi. He's a consultant medical oncologist at Shifa International Hospital in Islamabad. He's going to give us a talk on the changing paradigm in management of relapsed refractory diffuse large B-cell lymphoma. Dr. Azhar, if you can come on the stage.
Bismillah ar-Rahman ar-Rahim. Thank you so much, Dr. Bushra, Dr. Waqas, and Dr. Osman for inviting me. It's been always a great pleasure to be back at Shaukat Khanum, from where I did my fellowship. As I'll try to keep it as simple in the early morning rather than just bombarding you with the data and a lot of complex statistics. Few words about DLBCL, which we all know that it's the most common high-grade lymphoma. This is US data. And we know with chemoimmunotherapy, we have evolved with Rituxan-based chemotherapy, we can cure about 60% of the patients. It's true, but for young and fit patient, of course, we can still salvage them with high-dose chemotherapy and stem cell transplant. This has been the standard of care. Works pretty well for people who have late relapses, like more than a year. But the worrisome part, and which is sort of the focus of my talk, is it works pretty bad in people who have either primary refractory disease or early relapses. And above all, it's not an option for more than 50% of patients who have like age, comorbidities, and they can't go to high-dose chemotherapy and stem cell transplant. So focus of my talk would be on new and well-tolerated treatments in the second and third line, which have emerged recently for the last 5-6 years, like Pola-BR, polatuzumab, tafasitamab, and loncastuximab tesirine, and CAR T-cell as well. So let's look at the historical management. Just a couple of years back, what we were looking at is not time-bound. If somebody relapses, we know there are risk factors for DLBCL relapse, like high IPI score, age, comorbidities. In case of, regardless of timeline, we considered as if they were transplant eligible, take them to platinum-based chemotherapy like RDHAP, GDP. But just look at how the numbers drop. Just 50% would respond, and we, after demonstrating chemo responsiveness, we take them to transplant. And out of these people who respond, only 25 to 30% patient would be cured. But patients who are either not candidate for autologous stem cell transplant or who have primary refractory disease, they would fall into sort of a palliative care pathway for which we did not really have great options because they would have a very limited event-free survival. So this is what we are going to discuss now, how this is going to change. See, this is an old data looking at basically the role of stem cell transplant, high-dose chemotherapy, stem cell transplants versus salvage chemotherapy. But this was before the Rituxan came in. If we just concentrate on the right, the people who have now got chemoimmunotherapy like rituximab based, the number really drops. The event-free survival really drops that much. So difficult to treat this subgroup of patients who have previously had rituximab. And outcome in transplant eligible patient according to the time of relapse. So that's very important. This is a recent study from British Columbia, just looking at, see, if the patient has primary refractory disease, the 2 years PFS is just 13%. And early relapse, less than 12 months, just 22%. And late relapses, of course, we can salvage them. So the response to high-dose chemotherapy and transplant does depend on the time of relapse. So we don't have our own data. I just took this slide from the Danish lymphoma registry, just to emphasize one point, that the patient who relapse, very few, as we discussed earlier, very few of them go to the autologous stem cell transplant because of multiple reasons. And patients who are early, who have early relapse or refractory disease, even if the bottom line, if they go to the stem cell transplant, the chance of long-term cure is really remote, less than 5%. So this is sort of quite a dismal outcome. See, so just to emphasize, for the early relapses, patient or primary refractory disease, even if you take them to the transplant with a very high cost, toxicity, their outcome is not that good at all. The chance of long-term cure is 3%, which is pretty disappointing. So how has this changed in recent years? Now we have sort of a miracle in form of CAR T therapies, anti-CD19 directed CAR T cell therapy in refractory DLBCL. Just for my junior colleagues, the CAR T cell therapy is sort of is just like Rolls-Royce. You don't get Rolls-Royce off the shelf. It's manufactured. Very costly, just like Rolls-Royce. And so first step is apheresis. You get it from the patient T cells. Then you have viral vector delivers CAR T encoding into the T cells. It becomes a CAR T. Now the T cells express CAR on their surface and they are known as CAR T. And then there is in vitro expansion, complex process, takes time. See, in Zuma 7, where this trial was conducted, the minimum time was at least 13 days. It could be much more. So this is just to see one of the shortcomings of CAR T is this. And of course, we know it's not available in our country. It will be available soon, inshallah. So initially, as we know, that CAR T cells were initially tried in the third line setting, both Axicil, Tacicil, and Lisocil, Zuma 1, Juliet, and Trastuzumab. They have pretty much same event PFS, ranging around 35 to 40%, which is really amazing if you are using an intervention in the third line. So this is really a very, very amazing. And this is a comparison of these three trials. We see a PFS of 24 months of ranging from 32 to 40%, depending on the product you used, whether it's Axicil, Tacicil, or Lisocil. And the median OS ranging from 25 to 27%. Very impressive in the third line. So then we asked ourselves another question. Should we move forward and use it as a second line in high-risk patients rather than as a third line? So we came up with at least 3 trials, the Zuma 7, Transform, and Blenda. These were the patient population who relapsed within 12 months of therapy, or either they were primary refractory. And the primary endpoint is EFS, event-free survival. There's some trial design difference between 3. Zuma 7 did not allow bridging therapy except corticosteroids. And Zuma 7 and Transform met their primary endpoint, which is event-free survival. We can see Zuma 7 and Transform both having Kaplan-Meier curves nicely separated. And it's very impressive to see that after 24 months, the curves tend to flatten out, showing a durable response in a subset of patients, around 40%, 40 to 45%, both. Now we have updated survival, overall survival data for Zuma 7 as well, published last year in New England Journal of Medicine. Axicel versus standard of care, and we can see 4 years overall survival difference of about 55%. So now this takes us to a new treatment algorithm that if a patient relapses, we are going to look at whether this is a relapse less than 1 year, or primary refractory disease, or uh, like if the patient has relapsed within less than 1 year and is CAR T cell eligible, we are going to take the patient based on these trials, especially Zuma-7 to the CAR T, if this is available, with a projected cure of around 20 to 30%. But there is a significant group of patients who are either CAR T is not available, like in our country, or they are not eligible for CAR T because of comorbidities, because of toxicity. So more than 1 year, of course, is, as we discussed, autologous stem cell transplant standard. Rest, I've discussed CAR T and then we move on. But what are the basic limitations of the CAR T cell therapy? Number one, availability. We don't have it in our own country. The nearest countries we have it in China and in India. Quite costly therapy, and of course, a lot of logistics involved. It's quite have unique set of toxicities, so it precludes patients with poor performance status of significant comorbidities. And very important, patients with a poorly controlled disease, a rapid turnover, may not get to the CAR T cells because of the production time, and they are unlikely to benefit, may get bridging therapy. And some people, many patients will eventually relapse despite CAR T cell therapy. This brings us to the new novel agents recently approved in relapse refractory DLBCL. I'll discuss 5 of these, in fact. First is, as we know, polatuzumab vedotin, which is an anti-drug ADC directed against CD79B. We have initially data from the POLARX trial being used upfront in high-risk DLBCL. Tafasitamab, which is anti-CD19 monoclonal antibody. Loncastuximab tesirine, which is again an anti-CD19 ADC, and selinexor, which is inhibitor of nuclear transport. And Pola-BR and tafasitamab have been used for more than 1 prior lines, and loncastuximab and selinexor more than 2 prior lines. I'll briefly discuss these one by one. So we have phase 2 data for Pola-BR versus BR in patients who were transplant ineligible, more than 1 line of therapy, and they excluded patients with previous allotransplant and history of transformation. So this gives us a CR of around 40% as compared to Pola-BR versus BR, with nice separation of curves at 22.3 months. And in the extension cohort, we can see the survival difference persists with longer follow-up at 2 years, PFS of 28.4 months and 2 years OS of 38.2 months. And the side effects basically are cytopenia and peripheral neuropathy because of polatuzumab vedotin predominantly. So we had a real-world assessment of Pola-BR in relapse refractory DLBCL. And importantly, in this cohort, it was used as a bridge to CAR T cell therapy as well. Important to mention that if you are planning a Pola-BR, so maybe it's better to skip polatuzumab before leukapheresis. It may impair leukapheresis. So most physicians will end up giving just polatuzumab and rituximab and introduced bendamustine later because of this issue. Then we move on to our new tafasitamab, which is a monoclonal antibody, and lenalidomide. This trial design is slightly different than Pola-BR because it excluded patients who were primary refractory, slightly favorable group. Lenalidomide in conventional dose of 25 milligrams, day 1 to 21, was given only for 1 year. And tafasitamab, initially weekly, then bi-weekly, was continued till progression. So this is an infinite therapy. And we have pretty impressive data of CR of 42.5%, which is still like maintained with the longer follow-up. The difference, one of the differences is this is still progression, and BR, polar BR is a fixed number of cycles. So treatment side effects mainly in first year, cytopenias, diarrhea, and they like tend to resolve after you have stopped lenalidomide. For the sake of time, I'll skip this. So we have now LOTUS-2 trial with loncastuximab tesirine, which basically dealt with relapse refractory patients, more than 2 lines of therapy. And patients were given treatment for up to 1 year, but they were allowed to give if they did not progress. So almost similar, complete response of about 24% versus 23% with nice separation of curves. Similar safety profile except hypophosphatemia. Now, very important, and the last part of my talk is bispecific antibodies. So bispecifics are the antibodies who have high avidity binding to the CD20 on B cell, as well as engages CD3 on the T cell. And we have now a multiple bispecific antibodies, especially glofitamab and epicotamab, which are now FDA approved in the 3rd line. So this pivotal phase 2 study looked at glofitamab basically in the patients who have more than 2 lines of therapy, including anti-CD20 therapy. And glofitamab was initially given to mitigate CRS. Initially, obinutuzumab 1 dose was given, and there is a step-up dose of its complex step-up dose of glofitamab. And it's given for maximum 12 cycles. Again, a finite therapy. It's not given till progression. And we can see that there were patients who were post-CAR T cells, very high-risk group. And we have a CR of around 40% with this glofitamab, single agent therapy. Main side effect profile is CRS, we see, and this CRS basically mostly occurs in first 2 cycles, and it's really becomes negligible after you move on to the 3rd cycle or so, and the rest is cytopenia. But CRS was well managed with steroids. We have the other bispecific antibody, epicotamab, which is basically subcutaneous, not IV. And the difference is in this trial is this was given indefinitely till progression, not like glofitamab. And again, a complex dosing regime. We don't have to remember this. And a similar patient population. And almost the same CR, 40%. And significant number was post-CAR T. You see 34%. And this is the phase 2 data. We're showing the same toxicity profile with CRS. And see, the CRS is different than glofitamab, maximally 3 cycles, because the step-up dosing is different in this BiTE. And then we thought of like combination. Can we combine BiTEs with conventional chemotherapy? The STAR-GLOW trial, in which it was combined with glofitamab, R-GEMOX, our old regime for frail elderly versus glofitamab GEMOX. And we see 24 months overall survival of 33% versus 52%. So it's definitely better. But there is a question that most part is glofitamab rather than conventional chemoimmunotherapy. So very impressive is the duration of CR with bispecific with a longer follow-up. In recent publications, see, glofitamab was given, it's a finite therapy for just 12 cycles. Apicotamab is given till progression, but we have median CR of around 35 to 40% with a long-term follow-up. Maybe this question will be answered in the future trials. So my summary, now we have novel agents to overcome chemotherapy resistance in patients with DLBCL has emerged. CAR-T should be considered second line standard in refractory and early relapses, transplant eligible DLBCL or non-transplant candidates. But a very important question is, if a patient who is primary refractory or early relapse, and we do not have CAR-T, and if the patient goes into complete metabolic remission, would his outcome be same if some or the other we take this patient to the CAR-T or high-dose stem cell therapy? This is not proven by a randomized trial, but we have a publication in ASH last year by Dr. Mehdi Hamdani, and they're almost equivalent. So this subgroup of patients who some or the other get to CR, high-risk patients, even if we take them to transplant, we can probably do well, especially when we don't have CAR-T. So the next challenges for us will be in coming years is how to sequence them, what to use first. Can we combine this? And the sequencing will be very, very important. And of course, the need of the hour is that we should have predictive biomarkers to adopt a patient-tailored approach, which patient to offer what. Thank you so much for your patient listening.
Thank you, Dr. Azhar Shafi. That was a very good account of all the latest available options for relapsed refractory DLBCL. Our next talk, we'll take the questions in the end. Our next talk is by Dr. Khurram Tariq. He's a consultant hemato-oncologist at Selby V. Jones Regional Cancer Center in Bonn, USA. He has special interest in chronic lymphocytic leukemia, and his talk is titled Unraveling Landmark Clinical Trials and Demystifying the Current Treatment Paradigm in CLL.
Can everyone hear me? It's good. Well, I'm going through a little bit of a jet lag, so please excuse if I go off on a tangent or if I don't make sense. एक सेकंड, एक और चीज करनी है, अभी इसको टाइमर को रोक लेंगे। आप इसको थोड़ा सा पीछे कर सकते हैं। You can zoom out whoever is the cameraman here. अगर आप इसको पीछे कर लें, I'll be walking. If I stand here for too long, I'll pass out. तो मेरे लिए आसान है। अच्छा, so today we will be discussing CLL. I am Khurram Bilal Tariq. The idea is to make the landmark clinical trials and more understandable and also more practical when it comes to Monday morning management of CLL patients. So the idea is to really simplify the treatment paradigm as it pertains to NCCN guidelines. These are my credentials. So this is the picture I added last night, and I wanted to just show. This is one of my mentors, Fawzia Rana. I think she was one of the first physicians here at Shaukat Khanum, took care of 70 first initial patients. And she is the one because of whom I'm here, because initially I had no interest in hematology oncology, but she brought me here. This is the last day of residency training and a memorable picture. So anyways, I don't have any disclosures to make except for Beijing, but we won't be discussing any off-label use. This is the content. So let's dive right into it. So the management of CLL has really evolved over the last 80 years or so. Where is the hang on a second. इसका वो कहाँ है? Laser. अच्छा, दो मिनट. So the management has really evolved over the last 80 years or so, from management being mostly dominated by something like prednisone to it being dominated by targeted therapy in 2024. What does that mean? So let's just focus on this for a little bit. If this is your B cell and this is your transmembrane B cell receptor, then downstream from it, you have maybe close to 200 tyrosine kinases. One of them in particular is Bruton tyrosine kinase. And this is of particular interest because you have 3 covalent BTK inhibitors in the first line approved by the FDA. This is ibrutinib, acalabrutinib, zanubrutinib. And then you have a non-covalent BTK inhibitor, pirtobrutinib, that's approved in the third line setting. To the right, you have BCL2. The only inhibitor approved in this setting is your venetoclax. And then, of course, your CD20 inhibitors, which we're all familiar with, rituximab and obinutuzumab. Here is a summary slide to explain just that. So this is a snippet from NCCN guidelines, and as you know, the management is really divided on the basis of 17p deletion and TP53 mutation. Why is that the case? Well, historically, we have used the IPI scoring system, which predicts survival. There are multiple prognostic factors, each of them given a particular point on this grading system based on how much of a dent they can cause on the overall survival. The aggregate sum or the total number then determines how good or poor their overall survival will be. So as you can see, TP53 or 17p deletion is given the most weight on this chart. And this has to do with the poor overall survival that these patients tend to have. So, we were just talking before the talk how the advent of BTK inhibitors has really revolutionized the management of CLL. So let's just take a pause here. So before the advent of BTK inhibitors, the overall survival for a particular group of patients with 17p deletion or TP53 mutation was 1.5 to 2 years in the FCR era. And FCR is the meanest, the baddest treatment option. It is akin to FOLFIRINOX in the pancreatic world. But that has dramatically changed because this is a 6-year follow-up looking at ibrutinib frontline in this phase 2 trial in patients with 17p deletion. So the worst prognostic factor. And what it shows is that at 6-year follow-up, the overall survival is still 80%. So this is remarkable. Another slide, courtesy of Suzanne, is the use of ibrutinib in refractory CLL patient who had the submental and cervical lymphadenopathy. And just after 4 weeks of treatment, at least on physical exam, that disappeared. So they're very effective as well, is what I'm trying to say. And this is only about ibrutinib, which is not even the preferred first-line treatment option anymore. So let's dive right into it. We will first talk about the first-line management of CLL. These are some of the landmark clinical trials that we will focus on. I'll start off with the Alliance study. Why start with the Alliance study? Because this was the first BTK trial that looked at a meaningful competitor arm. Before that, there were CO and other competitors used, but they're not that meaningful. So anyways, ibrutinib with or without rituximab was compared with BR. 2 important key points. And by the way, before I dwell more into this talk, the idea is not for me to explain these clinical trials, but the idea is for me to go over why these clinical trials have been meaningful in the management of CLL. So 2 points to keep in mind from this clinical trial. One being that the ibrutinib arm was superior to chemoimmunotherapy. And the second point is that the addition of rituximab to ibrutinib did not have an improvement in PFS. So the benefit was mostly from ibrutinib, okay? So around the same ASH when this was presented, the ECOG 1912 phase 3 trial was also presented, here with a different competitor. IR was compared with FCR, the meanest, baddest chemoimmunotherapy of the time, which is also similar to the UK-based FLAIR trial, similar in design, similar in what they were trying to achieve. Both of them showed pretty much the same thing, that ibrutinib is superior to chemoimmunotherapy, okay? One thing to note here is that the FLAIR trial had a higher onset of deaths, cardiac deaths, and this is something that keeps popping up with ibrutinib. It may have to do with the median age being slightly higher at 63 compared to 58 in the US-based trial. So moving on, we have the ELEVATE treatment naive phase 3 trial comparing acalabrutinib with or without obinutuzumab, and comparing it with the worst chemoimmunotherapy option that was available at the time. This was no one's preferred option when you compared it with the BR and the FCR of the time. So anyways, 2 important points to keep in mind, one is what we already expected, that the BTK inhibitors were superior to chemoimmunotherapy. That's point number one. And number two is that surprisingly here, the addition of obinutuzumab led to a PFS improvement. This is not the case in the other three trials that I had just discussed. However, if you parse the data, you will realize that this benefit was only seen in patients without 17p deletion and TP53 mutation, because here the curves overlap. And these are important because they shape the management of CLL later down the road. So here is the ASH follow-up from 2023. A 6-year PFS follow-up shows that the trial, the BTK inhibitors are maintaining their superiority. As you can see, this was regardless of IGHV status. They all benefited. Now, moving on to the Sequoia trial, it created a lot of news a year or so ago. This is also a phase 3 trial. There are 3 cohorts. We'll just focus on the first 2. The first one looked at zanubrutinib and compared it with a meaningful chemoimmunotherapy, BR. And the second one just looked at 17p deleted patients. So at 2 and 4-year follow-ups, PFS was superior in the BTK zanubrutinib arm compared to the chemoimmunotherapy. And in cohort 2, patients who had 17p deletion, PFS was superior, about 90% at 2 years and 80% roughly at 4-year follow-up. There was no overall survival benefit. It was also much better tolerated, Zan was. And then at the most recent EHA, the PFS was also sustained, regardless of IGHV or TP53 mutation. So BTK inhibitors are great, but you have to keep them indefinitely. So let's look at the fixed duration options. CLL14 is what we will focus on. This looks at venetoclax plus obinutuzumab and compares it with a dismal chemoimmunotherapy option, the CO. The PFS was superior, and anytime you have venetoclax, you will also expect MRD negativity to be higher. And this is what this slide shows. At EHA 2023, the PFS superiority was maintained in the VEN-G arm. This is a slide that shows why VEN-based options are not the preferred option for management of patients in the first-line setting with 17p deletion. Because here, although these patients derived benefit, the curve dropped precipitously, and we don't want to use that. So let's switch gears and move over to the relapsed refractory setting. These are the clinical trials. So this is a very special space because they're head-to-head comparison of different BTKs. We'll start off with ELEVATE-RR, comparing acalabrutinib with ibrutinib. And basically, this while this trial did not show any superiority of one BTK versus the other, it did show that acalabrutinib was much better tolerated when it comes to AFib, hypertension, bleeding events, diarrhea, and arthralgia. Moving on to Alpine study, which compared ibrutinib with zanubrutinib. And similar design, surprisingly, this one did show that zanubrutinib was better in terms of PFS compared to ibrutinib. And it also showed its benefits in 17p deleted patients. Overall response rate was also good. And this benefit was seen across all subgroups, as can be seen here. Much better tolerated with fewer dose reductions and discontinuation rates. Cardiac toxicity was also much lower in Zanu compared to ibrutinib. The most important part in this slide is this number here. So there were 6 deaths in the ibrutinib arm compared to 0 in the zanubrutinib arm. And cardiac toxicity is one of the most severe toxicity in BTK inhibitors. So anyways, at the most recent ASH follow-up, the PFS was maintained, even when the the data was censored for deaths due to COVID and new CLL therapies. And here you can see that there were no new safety signals, and Zanu kept on showing that it was much better tolerated from a cardiac safety profile. So fixed duration, we have CLL14 in the first line. Here we have Murano. Couple of differences. While venetoclax is used, the partner is rituximab, not obinutuzumab, and it's a 2-year treatment, not 1 year as in the first line setting. So again, anytime you see venetoclax, you will expect a higher achievement of MRD negativity. And here the slide basically says that those who achieved MRD negativity had higher PFS. I mean, this is something we all expect. So, and the PFS was also higher, so was overall survival. There were no safety signals at 5-year follow-up. So what do you do if you have already exhausted your covalent BTK inhibitors and your venetoclax-based options? You look at Bruin trial. This was updated last year. And basically, it had a phase 1 safety with a built-in phase 2, looking at the 200 milligram dose. So the covalent BTK inhibitors bind at this site, and the non-covalent, which is pirtobrutinib, binds at a different site. The safety profile was similar to other BTK inhibitors. Here is the durable PFS reports out of ASH from last year. And because of this, FDA put out a press release approving pirtobrutinib for management of CLL after patients are intolerant or have failed 2 lines of therapy, including covalent BTK inhibitor and venetoclax. So GLOW trial, this is a trial with a great concept, but did not gain that much traction. It's a 1-year treatment with ibrutinib and venetoclax. And while it showed PFS superiority and some overall survival benefit, and since venetoclax was used, MRD negativity, it did not gain traction. It's not part of NCCN guidelines. I have 2 reasons that may have been the reason. One, that patients with 17p deletion were not included. So you're using the best of the very best drugs, combining them, and yet you don't have the heart to look at the patients with 17p deletion. That's one. And number 2 is that the competitor was CO. You're using the very best of both worlds, and yet you're only comparing them with CO. So that's that. These are some of the future clinical trials. I want to spend a little bit more time on the guidelines. So this, so I only have 4 to 5 slides left. So these are NCCN-based guidelines. This is what it looks like. And it looks very overwhelming and intimidating at times. But let's just simplify them. So these are your patients without 17p deletion, TP53 mutation. So these are the good cohort, patients with better overall survival, better prognosis. So you can start with a covalent BTK inhibitor. What were the 3? Ibrutinib, acalabrutinib, and zanubrutinib. Most recently, you would not use ibrutinib because it's not, because of the cardiac toxicities that we discussed. You will start with zanubrutinib or acalabrutinib. I would not do ven if given the option. Why? Because it performs inferior to BTK inhibitors in the 17p deleted patients. But here, you can use any of them. So you can start off with a covalent BTK inhibitor, Zanu, or Acala, or you can start out with ven with obinutuzumab. Chemoimmunotherapy is that. Don't use it if you can get away with it. There was a very minute subgroup, the best of the very best, IgHV mutated and TP53 wild type, and no 11q, those kind of patients, maybe, but not really. So I'll avoid chemoimmunotherapy. Spend a minute or so here. So once you start, because there are some pearls we can use Monday morning. One is that once you start patients on covalent BTK inhibitors, if they are tolerating well, you just continue that indefinitely or until disease progression. But if they're intolerant, just like aromatase inhibitors in breast cancer, you can just switch them out to a different BTK inhibitor. You can just simply do that. And use up all 3 covalent BTK inhibitors in that space. Once you have used them up, you can go and try the venetoclax-based option. Once you have exhausted that as well, say they're intolerant or they have disease progression, you can then use the non-covalent BTK inhibitor pirtobrutinib. Now, what if you start them on a venetoclax-based option and they show response, and after 3-4 years, the CLL honks back? What do you do then? Well, with venetoclax, you can always try it again. You cannot do that with covalent BTK inhibitors. But with venetoclax, of course, you can try it again. And it does not have the cardiac toxicities, the hypertension, so on and so forth. So a different safety profile. Here is another pearl. Here, it does mention obinutuzumab. So you can use obinutuzumab with acalabrutinib. However, because it did show PFS benefit in that Elevate TN slide that I showed. However, I would reserve this in patients with autoimmune problems and use obinutuzumab if I need to in that setting. I would not necessarily use if they did not have autoimmune issues that I need to deal with, or if they have 17p deletion or TP53 mutation. So I think those are some big take-home points. This slide explains all the different subtypes, different drugs that you can possibly use. And as you can see, ibrutinib is mentioned, but is not the preferred drug anymore. So this is your 17p deleted patients or TP53 mutated patients. And as you can see, you can start off with BTK inhibitor. Here it does mention obinutuzumab. I would not use it personally because it did not show a PFS benefit. So why add toxicity unless there are cytopenias that I'm dealing with? So that's that. And then the rest is similar to what we have already discussed. I would shy away from venetoclax. Why? Because one of the clinical trials that we discussed, CLL14, showed that there was a drop in the curves when venetoclax was used in TP53 mutated deleted patients, 17p deleted patients and TP53 mutated patients. So that's that, and this is just an expansion of all the drugs that you can use in this setting. There is some mention of CAR T-cell therapy, so on and so forth, but it's out there. It's not going to help you in Monday morning when you're looking at your patient. Even in US, we don't do CAR T-cell on a regular basis. So it's the shiny object, but it's not of practical use this very second. There's so many other drugs that we can use in between. So these are some concluding points. I'm not going to go over it, but it's there for anyone to review. And you can find clinical trials explaining each of these statements. So that's it. We still have a minute or so left. Let me just take a few seconds to just thank everyone here. I mean, this is a big undertaking that you guys do every year, especially in maintaining the quality of symposium that you guys do maintain. So thank you for first inviting me, and kudos to you for arranging such a quality event, to all the organizing committee. I know a lot of work goes into it. Rahil Bhai is here, and he knows how hard-staking it is. So thank you for giving me a chance to express my views. I'm here to answer any questions and for any future collaborations that you guys may have. Maybe we should look into doing clinical trials and do some things, add a few things that can energize fellows and residents and so on and so forth. So again, thank you so much. If you have any questions, I'm here, or I can just answer them afterwards. We only have 23 minutes, so let's just do question and answer afterwards. Thank you.
Thank you, Dr. Khurram. I have some burning questions, but we will do them at the end. And thank you for acknowledging all the efforts that goes in arranging the symposium. Our last talk is by Dr. Talha Munir. He's a consultant hematologist at St. James's Hospital, Leeds in the UK. I'm expecting it to be a very interesting talk because it's histiocytic disorders, which is something very rare that all of us hematologists come across. Thank you, Dr. Talha.
And thank you very much again to inviting me to talk about histiocytosis. I've got an interest with rare diseases, and histiocytosis comes into that domain quite nicely. So I'm a consultant hematologist working at St. James's Hospital, and it's my absolute pleasure to meet some of my mentors here as well, and some of my colleagues who I've worked with before as well. So it's a very big topic, and I'll try to take you through it. So just do bear with me because histiocytosis is not one disease. There are many diseases which actually incorporates this disease. These are my disclosures. So roughly the histiocytic disorders are divided into histiocytic neoplasms. And then you've got hemophagocytic lymphohistiocytosis, which I'm not going to talk about today. That's HLH. Or you also can be known as hyperinflammation or too much inflammation sometimes. And as we had a very nice talk about DLBCL, the CRS is primarily some of these patients are experiencing HLH, and that can be put into that basket. But for the histiocytic neoplasm, it's primarily an inflammatory myeloproliferative neoplasm of the monocytic or dendritic cell lineage. So my talk will try to look at what are these histiocytic neoplasm, where do they fit in clinical hematology, how do these presentations happen? Because a lot of these patients will actually not come to see us. They will go to a different specialty in the first place, and then we will end up picking up the pieces. What are the common presentations? And what is the cellular and molecular etiology in these patients? And what treatment options we've got for these patients? And talking briefly about the future of histiocytic diseases. So first thing to say is it was known that histiocytosis is a disease, but it was never recognized as a hematological malignancy in the first place. Now, the new WHO guidelines actually put this into the dendritic and histiocytic neoplasm state. And you can go down the bottom of the list. You have got the Langerhans cell histiocytosis or Langerhans cell sarcoma. And the main difference is that in the sarcoma patients, you've got a cell proliferation, which is very high. So your Chi67 would be very high on the biopsies. Whereas the histiocytic neoplasms, other types, could be juvenile xanthogranuloma, which we usually see in pediatric patients, or Erdheim-Chester disease. So first time I heard about this was watching House, and one of the programs did have one of these diseases, and it was, diagnosed by House at that point, but actually was completely a nonsense. Rosai-Dorfman disease, and then ALK positive histiocytosis, and then you see histiocytic sarcoma, which sometimes a lot of our myeloid colleagues deal with that as well. So what is this disease? Langerhans cell histiocytosis, Erdheim-Chester disease, and Rosai-Dorfman disease. And I'm going to talk about them in a moment. In terms of the sarcomas, you've got the histiocytic sarcoma, follicular dendritic cell sarcoma, Langerhans cell sarcoma, and most of them actually, main difference is that they have got a very high proliferation index. So there's difference in the cell of origin. So the Langerhans cell histiocytosis originates from Langerhans cells, and these are primarily present in the dermis, and that's where the primary mutation is happening. The non-Langerhans cell histiocytosis is xanthomatous. So these patients present with early onset xanthomas, and essentially these are originating from the dendritic cells. So Langerhans cells looks like Langerhans. You've heard about these Burbeck granules maybe once when we were reading our textbooks, CD1A positive, Langerhans positive, whereas the non-Langerhans cell histiocytosis, they look more like macrophage. So their immunohistochemistry is different. They are xanthomas. They have got two-ton giant cells. And in RDD or Rosai-Dorfman disease, you see this process of emperipoiesis. And the other problem that we see with this is the diagnostic uncertainty in these patients. So for LCH, you can see pathognomic changes outside the epidermis and the T cell zone. But the other diseases, it could be anything. And I think one of the things I would like to highlight is that don't ask your pathologist to make a diagnosis, a pathological diagnosis of ECD. And I'll show you why in a moment. So the problem now that we have got, if you go to any talks with LCH, all of the data is extrapolated from pediatric patients. The patients in the pediatric age group do very well with the treatments that we've got. But this is some data from NHS Digital, and that actually shows you that LCH is more common in adults now, and you're seeing far more cases in adults as compared to children. This is the incidence. It's very rare disease, 1.5 per million. But you can see in the last 5 years, there are more cases in the adult group. And this is what the histology looks like. It's typically CD1A positive, Langerhans positive. You could see on the James stain here, this is the stain with the CD1A and Langerhans. And these are the Burbeck granules, the tennis racket kind of appearance that you see on the electron microscopy. Whereas the Erdheim-Chester disease, the immunohistochemistry is different. So on the histology, you're seeing these two-tone cells. You've got these kind of lipid granules there. But these are CD163 positive, factor 13A positive, CD68, 14, and 163. So this is the monocytic lineages. You can see that the tissues have been taken from the kidneys, tibia, and that is where I will focus the talk later on, because that's primarily your site of disease. So if you want to really go into the pathogenesis and looking at the immunohistochemistry in these patients, these are some useful markers which actually helps you to distinguish, or a pathologist to help to distinguish which disease is which. So with LCH, it's pretty simple that you have got the CD1A, Langerhans, and ZBTB46 positivity. But in Erdheim-Chester disease and RDD, it's quite difficult to make the distinguishment. And OCT2 is a very useful marker to distinguish between RDD and ECD. So the problem with Langerhans cell histiocytosis is it can present nearly everywhere, but the most common site of disease is starts from the top. A lot of these patients will have lytic lesions, so it could be confused with myeloma. So one of the issues with this diagnosis, you do a biopsy, you're suspecting myeloma, but actually these patients have got LCH. And the disease area is usually confined to the maxillary region. So these patients lose a lot of teeth sometimes. And one of the other issues is neurodegeneration. So a lot of patients may have cerebellar signs as well. It can present as nodal disease, and pulmonary LCH is a typical LCH feature, which is usually seen in smokers or even vaping people as well. Liver, you can get sclerosing cholangitis. And if your liver, spleen, or bone marrow is involved, this is called the high-risk organ LCH. You can have the skin involvement, so virtually any area could be affected by LCH, but not every patient will have disease everywhere. Some patients will have pituitary involvement, and they will present to endocrinologists. So whenever I'm talking to endocrinologists, if they're seeing somebody with diabetes insipidus, they should start looking for one of these diseases. In terms of the staging of LCH, it can be single organ disease. It could be multiple organs, which could be risk organ negative. That is bone, skin, pituitary disease. Risk organ positive is marrow, liver, and spleen. You've got pulmonary LCH, and then you've got the neurodegenerative LCH. And this is what it can look like. You can see that some pictures here. You've got the CNS involvement here. This is the neurodegeneration in the posterior part. This is how bad the lungs could be of these patients. You can see an FDG-Evert disease in the vertebrae and a nearly complete collapse of this vertebrae here. That's what I was talking about, the maxillary involvement. And this poor chap's bone is completely eroded. You can see this rash. This is the axillary involvement in this case. So one of the other things to remember is the neurodegeneration. These patients have got a very difficult disease to treat. And what we find is that if the patient's if there is pituitary involvement or base of skull involvement, those patients have got a higher risk of developing neurodegeneration. And there is another test that we do in all of these patients. These patients are BRAF positive. So the RAS kinase pathway is mutated in nearly half of LCH patients. And if you do have a BRAF mutation, that does help you to get a new drug for those patients, but actually they would have a higher risk of developing neurodegeneration as well. The Erdheim-Chester disease is interesting disease because it's a very peculiar features that you see in this patient group. So this is a PET picture of this patient. And if you don't take anything from this talk, just take this picture really back in your mind. If you see a PET CT and this kind of high activity is seen around the knees and some other lesions elsewhere, this is, if you ask a radiologist, it's pathognomic of ECD. No other disease does that. And essentially, that's very important to recognize that if you have got any diagnostic uncertainty, ask for a whole body PET CT. Because most of the times we do a half body PET CT because for looking out for lymphoma and other things, but the whole body PET CT is very useful in these patients. These patients can present again with neurological involvement, pituitary involvement. These patients can have coated aorta, so aortic thickening, or left atrial masses. That is very common. You can have lung infiltrates. And this other feature, which is called the hairy kidney, again, is not seen in any other disease apart from Erdheim-Chester disease. Extremely rare, but very typical radiological findings, which you see in these patients. And this is the other kind of pictures I've put forward. These patients could have lesions in the skull. You can see a pituitary mass here. Proptosis, one of the reasons these patients can have bulging eyes because there is these retroorbital masses, which will push the socket outside. Early age xanthomas, again, one of the very common presentations of ECD. And it's very useful because you can easily biopsy this site, and actually will be heavily, if they have got a BRAF mutation, you'll pick it up there. And it's very easy to biopsy, so rather than going in somebody's brain to get a biopsy. This is the aorta. You can see the aortic thickening around here. And this is the pericardial thickening that you're seeing here. This is how the hairy cell kidney looks like. So you can see the kidney here, but then there's kind of hairy-like structures that you're seeing, which is again, even seeing on the CT scans. So I think these are quite peculiar features that you will see. Juvenile xanthogranuloma more commonly seen in younger age group, and they kind of have the same feel of Erdheim-Chester disease, but more benign feel. It doesn't behave in a very malignant way. And Rosai-Dorfman disease is a very benign condition. I'm briefly going to talk about it, but this is the kind of the imperipolesis that you see on these patients. These patients primarily have got nodal disease, and that's how they present. So in terms of the Rosai-Dorfman, extremely rare, more in younger group, two types. One is nodal and the other one is extranodal. You can see the nodal type, quite easy to pick up the lymph glands here. Some of these patients will have neurological involvement, but the extranodal disease can present in different ways. But paranasal disease and bone disease is pretty common in these patients. But the Rosai-Dorfman disease can be associated with a number of other conditions. So this is what they famously call the Faisalabad mutation, the germline mutation of the SLC 29A3. It's pretty common in Pakistani community in UK, where consanguinity is very common. And in that group, we are seeing families with 10 family members with RDD. So it's clearly a thing. Then we have got this FAST gene mutation and ALPS1 disease. You will find sometimes lymphomas with RDD. So sometimes we find in a biopsy that you've got clearly a non-Hodgkin's lymphoma there, and you've got an RDD pattern. And usually the mantra is you have to treat the non-Hodgkin's lymphoma, and RDD will go away. Then you've got immune-related RDD, and you treat the immune-related problem in the first place. And one of the mimicking diseases, IgG4 disease, which is quite difficult to diagnose sometimes when you have got concomitant RDD. So these are the clinical presentation, and each circle is showing which disease area is involved more. I wouldn't dwell into a lot of that because this is just for helping you to make guidelines. Helping you to make a kind of a diagnosis. But the important thing to remember is that clonal hematopoiesis is pretty common in ECD. Some of these patients actually will have a myeloid mutation. And you can see that your usual culprits like TET2 mutation, ASXL1, DNMT3, all features in this group. Well, one of the most important thing is the BRAF mutation. Nearly half of these patients will have a BRAF V600E mutation, and some of these patients will also have a TET2 mutation. And as you see that the median age of ECD is around 50, as the age grows further, the myeloid mutation landscape increases, and that the same is true what you see in ECD. And you can have crossovers as well. In the same patient, you might have an LCH in one place, and you might have ECD in the same place, but they're invariably mutated for BRAF. So it probably is originating from the same clone, and essentially gives rise to two different outcomes. Then you have got the MAP2 kinase pathway, which is also mutated in these patients, which is nearly up to 20% of these patients where you will find a MAP2 kinase mutation as well. And if you look at the myeloproliferative neoplasm, you've got this JAK2 CALR activation, but in histiocytic neoplasms, you can have multiple receptor pathway mutations, which causes the activation of the PI3 kinase pathway or the NRAS or KRAS pathway. And as a result of that, you've got the monocytic and dendritic cell development. And this is what I was talking about, that the BRAF mutation is more common in LCH and ECD. You're seeing the MAP2 kinase mutations there as well. In RDD, you see MAP2 kinase mutation, but less common. In JXJ, you've got more CSF1R mutation, and the RAS mutations do feature in the non-Langerhans cell histiocytosis. And essentially what you find is that you need to do a very deep sequencing in these patients to find these mutations. So if you use Sanger sequencing, you're going to pick out a mutation if there is a 15% clone which is harboring these mutations. So you have to go down a bit deeper, less than 5% with next generation sequencing to pick up these mutations. Remember that histiocytosis is a slowly proliferative disease. It is not, you're going to need a proliferating fraction to pick up these mutations. But you can pick it up in just peripheral blood. You don't need to go into the biopsy, the individual area to pick it up. So lastly, coming down to treatment, the first line treatment for LCH, in some patients, if you've got unifocal disease, if you just biopsy that, sometimes there's spontaneous resolution. So you just don't need to do anything. Bisphosphonates are quite useful, and indomethacin is a very useful drug to control the pain in these patients. Then you can go to the old treatment with how we used to treat our kids with vinblastine and steroids for a year. But usually the adults don't tolerate vinblastine and steroids for a year. Most of them end up having severe peripheral neuropathy. And I normally don't use vinblastine in that scenario. Normally the other treatments are cytarabine or cladribine, and I'll go through that in a bit more detail. But for maintenance, methotrexate or hydroxycarbamide is very useful. And if you do find a mutation, then BRAF inhibitors work very well. If you don't find a mutation, MEK1 inhibitors work very well for these patients. And this is what I was trying to show before. The survival data is pretty poor in these patients with Langerhans cell histiocytosis. Briefly, we'll go through this patient. This is a patient who had LCH with horrible disease, and we treated him with cytarabine, but he had a very difficult case, and then he was found dead at home. And unfortunately, LCH was not even written on the death certificate. So these patients do die of this disease. For unifocal disease, surgical resection or radiotherapy is very useful. Multisystem disease, if you've got critical organ involvement, you've got the kinase inhibitors. For bony disease, weekly methotrexate, indomethacin, or bisphosphonates are very useful. For pulmonary LCH, ask the patient to stop smoking and vaping. And essentially, some of the patients will have spontaneous resolution. But low-dose cytarabine is the treatment of choice. And for skin LCH, you again are going for topical therapy, methotrexate, 6-MP, or thalidomide or lenalidomide. For ECD, I like to use low-dose methotrexate for low-risk disease or pegylated interferon. They both work very well. For high-risk diseases, BRAF inhibitors are very useful. This is a patient who was treated with BRAF inhibitor, and you can see that the activity just came down very nicely, and the BRAF mutant clone went down as well. This is, again, a young kid where the nodes essentially disappeared, and the disease activity score came down very, very nicely. And for neurodegeneration, dabrafenib crosses the blood-brain barrier, and you can see that the lesions have disappeared in this patient on dabrafenib. MEK1 inhibitors, these are other drugs like trametinib and cobimetinib, and they do work for this condition as well. And the problem is that if you stop the inhibitors, the mutants then start to come back again, and you can see the relapses in these patients. And the peripheral blood mutations do stay on the inhibitor. Sorry, I'm rushing a bit now. For RDD, essentially, you have to can observe these patients or surgical resections. Steroids are the mainstay of the treatment, but if the steroids don't work, you've got all of these options, and MEK1 inhibitors do work very nicely for these patients. I think I will skip those slides. I think the other thing you need to remember is that there is toxicity associated with RAF inhibitors. All of these data come from melanoma studies. So the doses that are given there at the moment are not the doses that you need to use in histiocytic disorder. And essentially, I've been told that I need to stop. But what reduction in dose is definitely required. I normally use a quarter of the dose, and that usually works for these patients beautifully. So I think that would be my message. I think these are rare diseases, but not as rare as we think. There are said to be only 550 cases of ECD, but 60 of them exist in Leeds at the moment, which I think is not going to be the true prevalence of the disease. You have to think about pathway inhibitors if you don't treat RDD or LCH or ECD this patient. And I think if you have a case, we've got a histiocytic MDT every fortnight in UK. It's a Teams call. If you have a case, just email me and you can come and discuss that patient. Thank you.
Thank you very much. And we have very exciting and fascinating first hematology session of Shaukat Khanum Cancer Symposium. Now it's open for the discussion and question answer from the audience. Any question from Tala?
Zoledronic acid. Jakavi, okay. The JAK2 inhibitors. So most of the patients in histiocytic disorders with the JAK2 inhibitor, if you do find a JAK2 mutation, they usually have a myeloproliferative disorder concomitantly with ECD. And we have got patients who've got MPD, CMML, and JAK2 mutation. And if you give them JAK2 inhibitors, they work. But primarily, they're affecting the CMML clone or the myeloproliferative clone. But if that was originating from the same lineages, then the ECD should be helped as well. But invariably, we have seen concomitant BRAF mutation in those patients as well.
As you said, rare, but we do see Rosai Dorfman. We've seen a couple in our hospital, and I think you guys have seen 5 or 6 cases in yours. And the problem is that, as you said, the BRAF mutation is not so much of a marker in them. And then we don't have BRAF inhibitors anyways. And for them, what is the preferred choice? What happens is they're already on steroids because they have been all around before the diagnosis is made. And then by the time we get the PET, either they're just disappear or they're too unwell.
Yep. So if they disappear, I'll just monitor them. If they still are showing disease activity, one of the things I do is I bring down the dose of steroids and put them on methotrexate as a steroid-sparing agent. Single agent methotrexate works very well for some of these patients. If they got immune phenomenon with RDD, I would normally go for drugs like sirolimus in these patients. There's good data for sirolimus in this condition. If they still relapse, cobimetinib or trametinib. Now, these are melanoma drugs. These are available. And you nearly need a third of the dose, because if you give a MEK1 inhibitor to any patient, they'll get acne, horrible acne. So all of these patients needs to go on a minocycline or a tetracycline alongside a MEK1 inhibitor. But you don't need, the full doses that melanoma guys will give. The only problem with the MEK1 inhibitors is if you look at the PFS data for melanoma, where they're used is for a year. So you can tolerate that kind of drugs. These patients can live for 10, 15, 20 years. So you need to just manage the toxicity as you go along, really, in these patients.
Okay, there is a question. Yeah.
One question.
Medical oncologist. Right now, I'm not practicing immunology, but after I saw your presentation, just a case came across which we published maybe in 2019. That was ECD. It just felt that patient the disease had just read the textbook. She had typical proptosis. She had cardiac involvement. She had retroperitoneal fibrosis. She was morbidly obese, couldn't really walk. So at that time, things were not very clear. She did have BRAF mutation, but of course, we don't have the targeted therapy for that. We treated that patient with interferons. So what are your thoughts about that in current time? That was back in 2015-16.
So the problem with these patients are they come very rarely. And I think if somebody has got risk organ, such as cardiac involvement and CNS involvement, at this moment in time, I would go for a RAF inhibitor. In 2019 or 2015, when we used single agent methotrexate in these patients for 6 months. And if they are still PET positive, then we can sometimes try pegylated interferon. but the responses are not durable on these drugs. And like I said, I've got a number of patients are vemurafenib and dabrafenib at the moment, but I'm using very small doses. So normal dose of vemurafenib is 960 BD. I've got a patient on 240 milligrams once a day. So even very small doses work for these patients. And if I've got a risk organ involvement, I would definitely give them a RAF inhibitor. And I'm not sure whether the availability is an issue. I think these drugs are available, but I think the dosing is definitely, if you give a quarter or eighth of a dose, the pricing, the cost would be substantially low.
Yeah. Thank you. There's, yeah.
It's more of a CLL related question. So I think Dr. Khurram as well as Dr. Zala both can answer. So it's a practical question. So a patient with a newly diagnosed CLL who needs to have treatment, P53 not mutated. And obviously we counsel them about different treatment options. And as Dr. Khurram mentioned, there's a whole raft of treatments, especially the newer ones. But the answer we get in our clinic is, whatever you say, doctor, जो आप कहें वो treatment दे. So, how do you counsel that patient? You go for venetoclax-based fixed, duration treatment, or you keep, go with ibrutinib, especially if it's a young patient, say, less than 50 years of age.
I'll let him have the answer first, and then I'll take that later. Please go ahead.
So that's a good question. Because there are two types of patients, right? One who will let you make the decision, and the other ones who have already consulted Dr. Google, and they come in and they have all the answers, but they're off, right? So so the bottom line is, what kind of toxicities will they be able to tolerate? Because your BTK inhibitors, especially zanubrutinib and your acalabrutinib, are both fine in the 17p deleted space, or in the one that you mentioned, in wild type. But in wild type, you can also start off with the fixed duration. And I think that was a question that Nida asked as well. But because of that clinical trial that I showed, CLL14, where last year Al-Sawaf mentioned how the PFS dropped from 76 to down to 50 something, especially when venetoclax obinutuzumab was used in the TP53 mutated patients. So it gets a little complicated, but you will look at the toxicity profile. So for example, patient comes to you, has migraine headaches, right? And you have access to both acalabrutinib and zanubrutinib. You would not use acalabrutinib. Why? Because in one of the clinical trials, I think it was Elevate RR, there was an incident of 40% headaches associated with acalabrutinib. Now, let's assume another patient who is forgetful. Family is there and they say, bhul jate hain dawai lena. So in that case, you will go towards zanubrutinib. Why? Because it has two different dosing options. You can do 2 and 2 pills, like a BID dosing, or you can take all 4 pills at once. So that makes life easier. Now, I did not have time to show the kinase dendrogram for ibrutinib, acalabrutinib, and zanubrutinib, but they all have different toxicities. And depending on the toxicity that they have, you can then choose between acalabrutinib and zanubrutinib. I would not use a ven-based option if I have the choice in a first-line setting in patient with 17p deletion because of the curves and how it dropped. But it's a great option, especially in a younger patient. And why do I say that? Because BTKs have another issue with them. They can cause secondary malignancies. So I had a patient, and I'm sorry if I'm taking too much of your time, but I had a patient who was on a BTK. I think he was on Xanu for Waldenstrom. And then a very fit guy, would run marathons, non-smoker, and all of a sudden he developed pleural effusion. We tapped it, and it was adenocarcinoma, non-small cell lung cancer, but no mass anywhere, very atypical. So this is likely from the BTK inhibitor. So something to be cognizant of. And especially if they have hypertension, hemorrhage, cardiac issues, then you want to stay maybe away from BTKs and go towards VEN. The good thing with VEN is that you get, if they respond, you get maybe 5 years or so, 4 to 5 years, and then you can try VEN again, So you have not used up your second line option. So it really depends on patient preference. And if that's not an issue, then toxicity profile, dosing issues, their mentation, ECOG performance status, their age, all those things. I hope I answered that
Dr.
question.
Salah, do you think in our part of the world, because venetoclax and venetoclax is a fixed duration treatment versus the indefinite treatment, and then, as you said, you still have a second line available, and then you can repeat the treatment. So if it's not 17p, would you prefer that in this part of the world?
So I think that's the option you are asking about is what would you be your preference? Because patient has put the ball in your court. And I think that will then come down to what you feel is patient's ability to tolerate the treatment, the cost of the treatment. That's important because BTK inhibitors, you need to keep on going as long as it is working for you. So that might be okay in UK or US jurisdiction. It might not be everywhere. The second thing to say is then it comes down to the genomics of the disease, and very rightly said very eloquently about the TP53. But we only see 10% of the cases with TP53 aberration in the frontline setting. Most of our patients, unmutated IGHV status, those are the patients who form the bulk of the CLL group. The 40% are the IGHV mutated patients. So I normally go for a fixed duration option in these patients, providing they don't have renal impairment and those kind of issues. For mutated IGHV patients, I think Venobi is an excellent option. We do use I+V in UK, and for unmutated IGHV patients, you see a very good response, but 15 months of I+V is not the right duration of therapy, in my personal opinion. We are going to show some data from ASH for FLAIR, where we're giving slightly longer I+V. And the toxicity is absolutely the key here. But I think in places where cost is an issue, fixed duration options are, and I think the other point you're making, retreatment, there's actually no data. I would argue that when you retreat patients after a fixed duration therapy, we have got no data in the second line setting. All the VEN-R patients were treated with chemoimmunotherapy. They were not treated with targeted agents in the frontline space. And that data space is completely empty at this moment in time. So.
Thank you very much for excellent talks. So first of all, a couple of comments regarding treatment of CLL in our part of the world. So I still believe that chemoimmunotherapy remains a valid option in our part of the world, especially in patients who are non-17p, TP53 mutated, and those patients who are IGHV mutated patients, because we know data from FCR that patients who are IGHV mutated after 4 to 5 years, we do get a plateau, which then continues. So FCR and BR remains a valid option, especially because we have got only 2 options available with us, ibrutinib. Acalabrutinib is available off and on. Sometimes you are able to get it imported or not. And that is another one is venetoclax. And if we do expose our patients upfront to ibrutinib or venetoclax, then afterwards treatment sequencing would be a problem, especially the median age of CLL, which we see is quite younger. That would be, I think, in mid-40s. So continuous treatment with BTK inhibitor would be a major problem, especially considering the cost. And just another couple of questions, and I'll be sharing a case of just Dr. Bushra mentioned regarding Roside-Hoffman.
Yeah.
So we do see a lot of Roside-Hoffman actually. And many of them are benign, but many of them are not very benign. So one of our patients recently, around a year back, he was Roside-Hoffman, classical histology, and we followed him for 3 years, initially with steroids, then he progressed, we rebiopsied, it was Roside-Hoffman, started on MTX, there was no response, added 6-MP, there was a partial response, he continued for 2 years, and after that, he presented with classical type B symptoms, we biopsied him, and he had diffuse large B-cell lymphoma. So we do see transformation as well in these patients. So this was the case. And secondly, I'll be asking a question that is frequently asked from us, from our critical care colleagues, that is regarding secondary HLH. So secondary HLH, because we have a lot of infections, so secondary HLH is very common. And these patients are often admitted in intensive care with high H scores. The first line treatment steroid is started, and more than 50% of the patient do not respond because the underlying diagnosis is still waiting. And there is always a temptation by them and from hematologists to add second line treatment that we know from HLH protocol is etoposide, but we also know that the mortality of etoposide, especially in critical care, is more than 80%. So we started in our institute on second line anakinra and IVIG as options, but we haven't seen very good responses with that. So what would be your comments and expert advice for those patients who have not responded to steroids?
Yeah, I think very good questions, really. And HLH is very much dependent on what's happening, you know, why HLH is happening in the first place. So, for example, with CAR T cell therapy, you know, you need to ride out the storm, and you probably will be able to manage that. But if you're seeing that kind of case, throwing more drugs at the same time at that critical period is going to help to stop the process. So anti-IL-6 therapy, you know, anakinra is very useful. We use tocilizumab and ziltuximab in these patients as well, occasionally rituximab as well. So you're trying to dampen the hyperinflammation as quickly as possible. My view on this is that rather than prolonging the ITU stay, you try these drugs quickly. And if they don't work, then you think about palliation in those patients. I think the issue is that when you have started this process, you need to act on that pretty quickly. And we have become very good in managing CAR T cell toxicities now because they're very strict protocols. You know, the junior staff knows if somebody's getting a fever or they're scoring high, you have to give them steroids at a high dose. If the fevers don't settle within 24 hours, you're going on to Tossi very quickly. If that's not working, you're going to siltuximab very quickly. So essentially, you need to work, and at the same time, you need to look at why the the HLH is happening, because it's an aftermath of something else which has triggered that. So along the same lines as what you're doing, and like I said with RDD, your point is absolutely valid that most of these patients will have a concomitant disease. And essentially, the problem is you can't biopsy everywhere. And I think PET-CT is very useful, and targeting the biopsy based on the PET-avid lesion is very, very important in these cases.
There's an online question for you. Dr. Halima Saeed is asking, can you please comment on treatment of isolated intracranial histiocytic sarcoma that is fully resected?
Monitor. Because the problem is you give them high-dose chemotherapy. We tried giving them DAR and AID or R-CHOP. So we treated ourselves basically, and the outcomes have been dismal in those patients. If they have been completely resected, they probably will do okay. You can probably give as much toxicity to patient by giving these therapies. Unfortunately, I take a very dim view on it that these patients actually don't respond very well. I've tried to give inhibitors to these patients, and especially with CNS disease, unfortunately, that's very, very difficult, although all of these drugs do cross the blood-brain barrier.
There's one last question online that is for Dr. Shafi. Dr. Nidanvar from NIBD is asking, you mentioned when deciding between CAR T and stem cell transplant, certain predictive biomarkers can be used. Are there any already available, or are they in research?
Thank you so much. So all of this is in research. I don't think so that we have readily available biomarkers to help us decide this high-risk group, what to offer and what the sequence should be.
Yeah.
I think more clinical enigma which we are facing is in our high-risk group, which is either primary refractory or relapsed, how to put them into remission, especially when you do not have access to CAR T. Because the way we get it in the clinical practice, if we give them platinum-based chemotherapy, it doesn't work very well. accept toxicity, and it comes with like some of these patients, even if you get them to CR, they have developed irreversible toxicities like nephrotoxicity. That's another question. It's just food for thought that we have this polatuzumab Pola-BR trial comparing BR versus Pola-BR. Should we be considering it if affordability is not really an issue as a first salvage in our high-risk group? Because recently we have seen really very interesting results. In fact, one of my patients, primary refractory, has gone into complete metabolic remission after having failed 3 cycles of platinum-based chemotherapy. And just to discuss, I didn't get time to discuss the last year this in ASH meeting in December, Dr. Mahdi's Hamdani's review. This is a retrospective review of the CI-BMTR data, which is showing that a small fraction of patients, if you get them into CR, some or the other, even if they are high-risk group, probably their outcome would be similar. So just to cut it short, right now we don't have that predictive biomarkers. Thank you so much.
Thank you very much. Professor Nisari, you want to make a comment? Okay. So thank you very much, all the speakers. That was very interesting discussion and excellent talks, excellent summary on CLL. With that, yeah, histiocytosis and DLBCL. Thank you very much. I think we'll have tea before we start our next session. At 11:20, we'll have our next session on transplant.